Welcome to the Deep Dive, where we jump into your sources and pull out what you need to know. Today's dive is super focused. It comes from revision notes one of you sent in, centering on just one specific but really important neurological condition, our job. Take these dense notes, find the absolute must-know high-yield stuff, and, well, make it make sense, make it stick. Good for revision, or just getting up to speed quickly. We'll follow the notes. Definition, causes, signs, management, the whole lot. Ready to get into it.
Absolutely. So the condition we're tackling today, straight from these notes, is third nerve palsy. You'll also hear it called oculomotor nerve palsy.
Okay, third nerve palsy. Let's start right at the beginning. The notes define it as dysfunction or paralysis of the third cranial nerve. Simple enough, but maybe the key question first is, what does this nerve actually do? Why is it so important?
That really is the foundation for understanding everything else. The third cranial nerve, well, it does a lot. According to these notes, it's got three main jobs. First, lifting the eyelid, opening the eye properly.
Okay, eyelid up.
Second, controlling the pupil size, specifically making it constrict, get smaller. And third, it handles most of the movements of the eye itself.
Most movements. Which ones are we talking about?
Yeah, the notes highlight the big ones. Moving the eye up, moving it down, and moving it inwards towards the nose. And like I said, it also powers that muscle holding the eyelid up.
Got it. So if this nerve isn't working right, you'd expect to see maybe a droopy eyelid, potentially a pupil that looks a bit off, and the eye struggling to look up, down, or in. That paints a picture straight away.
Exactly. Those are the functions, and the signs we'll get to later are basically what happens when you lose them.
All right, let's dig into the why. What can actually cause this vital nerve to, well, pack it in? The notes have a pretty hefty section on etiology, the causes. Looks like quite a list.
It is a long list, and knowing the potential causes is crucial for figuring out what's going on and how to treat it. The notes break them down neatly. You've got ischemic causes, basically not enough blood flow getting to the nerve.
Okay, like a mini stroke affecting the nerve.
Sort of, yeah, related to vascular issues. Then there are traumatic causes, direct injury, maybe from a head impact or physical compression. And the notes also list compression more generally from things pressing on the nerve, like aneurysms, tumors, or vascular malformations.
Compression sounds particularly serious.
It often is, and the notes really highlight one specific high-yield cause here, a posterior communicating artery aneurysm. This is critical because an aneurysm pressing on the nerve is often a medical emergency.
Right.
And importantly, the notes point out that when an aneurysm is the cause, it tends to present with that pupil dilation we mentioned and pain. That combination can help distinguish it clinically.
Ah, okay. So pain plus a dilated pupil alongside the eye movement problems should make you think aneurysm, think compression, think urgent.
That's precisely the takeaway the notes emphasize. It's a really important distinction. Then we also have inflammatory causes listed, things like ophthalmoplegic migraine or Tolosa-Hunt syndrome, and infectious causes too, like ophthalmic zoster shingles affecting the eye area or bacterial meningitis.
Wow, okay. So blood flow problems, physical pressure, inflammation, infection. That's already a big range. The notes seem to list a few more specific conditions, too.
They do, yeah. Systemic conditions get a mention, like diabetes mellitus, very common, and different types of vasculitis, specifically temporal arteritis and SLE are named. These affect blood vessels and nerves. Then there's something called a false localizing sign. This is quite interesting. It's when raised pressure inside the skull, maybe from a tumor elsewhere, causes part of the brain, the uncus, to herniate, to push down onto the third nerve.
So the nerve itself isn't the primary problem site, but it gets squeezed because of pressure building up somewhere else entirely.
Exactly. The palsy sign points you to the nerve, but the root cause could be raised intracranial pressure. It's a crucial thing to remember.
Definitely need to think bigger picture then.
Absolutely. The notes also list cavernous sinus thrombosis, Weber's syndrome, that's a specific midbrain stroke, causing third nerve palsy on one side and weakness on the other side of the body, amyloid deposits, and multiple sclerosis.
Okay, that is a lot of potential causes. For anyone revising, trying to memorize that whole list, cold is tough. I always find grouping helps. Maybe think like vascular stuff, ischemia, diabetes, vasculitis. Yeah. Then things pushing on the nerve trauma, compression from aneurysms or tumors, that false localizing sign from brain pressure.
Right. physical causes.
Then inflammation or infection, the migraines, Tolosa-Hunt, zoster, meningitis, MS, and finally those specific named syndromes like cavernous sinus thrombosis or Weber's. Kind of chunking it makes it feel less overwhelming, just like the notes seem to do with their categories.
That's a great revision strategy. Using those categories really helps structure it.
So with all these possibilities, are certain people more likely to develop a third nerve palsy? What do the notes say about risk factors?
Yeah, the notes list factors that make it more likely, and, they link straight back to the causes we just ran through. Older age is one.
Okay.
A history of vascular conditions, like high blood pressure that links to the ischemic causes,
Sure it
right?
says.
Also, a history of trauma or head injury, naturally. And having known underlying conditions like diagnosed aneurysms or tumors nearby.
It makes total sense. High blood pressure increases risk of small vessel blockage. An existing aneurysm, well, that's a compression risk waiting to happen. The risk factors just underline the causes.
They really help narrow down the possibilities when you see a patient.
Let's switch gears slightly to the how. How does the nerve actually, fail? What's the basic mechanism, the pathophysiology, according to these notes?
At its core, the notes say it's about disrupting the normal signals to those eye muscles and the eyelid muscle that the third nerve controls. That disruption causes the weakness or paralysis. Simple as that.
And I guess the way it gets disrupted depends on what caused it in the first place.
Exactly right. The notes detail the different mechanisms, and they map directly onto those cause categories we discussed. If it's ischemic, the mechanism is vascular compromise, the nerve's blood supply is cut off or reduced.
Starved of oxygen and nutrients.
Precisely. If it's an aneurysm or tumor, the mechanism is compression, just straightforward physical squeezing. If it's something like ophthalmoplegic migraine, it's inflammation affecting the nerve. And with trauma, well, it's direct nerve injury.
So the pathophysiology isn't some separate complex thing. It's just how the cause damages the nerve. Lack of blood, being squashed, inflammation, or being physically broken.
You've got it. Understanding that link reinforces why identifying the cause is so vital.
Okay, we know what it is, why it happens, who's at risk, how the nerve gets damaged. But clinically, someone walks in, maybe they've got a droopy eyelid, seeing double. How do you know for sure it's a third nerve palsy and not something else that might look a bit similar? The notes mention differential diagnoses. What else needs to be considered?
Yeah, this is super important in practice. The notes list conditions that can sometimes present in ways that might initially confuse you. They mention fourth nerve palsy, sixth nerve palsy, Horner syndrome, myasthenia gravis, and internuclear ophthalmoplegia.
Okay, why those specifically? What's the overlap and what are the key differences we should look for based on these notes?
Well, the notes imply they all can cause issues with eye movements or eyelid position or pupils, but in different ways. For instance, a fourth nerve palsy mainly messes up looking down and inwards. A sixth nerve palsy affects looking outwards. So different specific movements are affected compared to the third nerves up, down, and in pattern.
Got it. Different movement problems. What about the others?
Horner syndrome affects the pupil and eyelid, but it's kind of the opposite pattern. You get a small constricted pupil miosis and usually only a slight eyelid droop, not the big dilated pupil and often significant ptosis you see in a complete third nerve palsy, myasthenia gravis. That's a condition affecting the junction between nerves and muscles. It causes muscle weakness that gets worse with use, often hitting the eye muscles first. So it can mimic a palsy, but the weakness fluctuates, and it's fundamentally a muscle connection problem, not the nerve itself being damaged.
Right, so the key isn't just something's wrong with the eye. It's about the exact pattern. Which specific movements are out? How droopy is the eyelid? And crucially, what's the pupil doing, big or small?
Absolutely. Careful examination is everything. Maybe a quick scenario for you listening based on the notes. Imagine someone comes in, they've had some neck pain radiating to their shoulder maybe, and you notice their upper eyelid is only a little bit droopy, their pupil on that side is small, and maybe they mention that side of their face feels less sweaty. Could that be a third nerve palsy?
Based on what you just said and the differentials, small pupil, slight droop. That sounds more like the Horner syndrome pattern you described, not the third nerve.
Exactly. That specific cluster of signs, slight ptosis, meiosis, maybe anadrosis, points strongly towards Horner's, not a third nerve palsy. It shows why knowing the specific features of each is so important for differentiating them.
That example really drives it home. Knowing the details matters for revision.
It really does. You can't just lump all eye movement problems together.
Okay, what about how common this is? Epidemiology? Do the notes give us any numbers?
The notes say that clear figures on prevalence or incidence aren't really well documented. Generally, though, it's considered relatively rare overall.
So not something you see every day.
Probably not. And how often it occurs really depends on the underlying causes in a given population. So in an older population with lots of high blood pressure or diabetes, you might see more of the ischemic type, for example.
Right, so relatively rare, but the frequency links back to the prevalence of the causes. Makes sense. Now, the really crucial bit for actually recognizing it clinically. What does third nerve palsy look like? What are the absolute key signs and symptoms we need drilled in for revision?
This is where knowing the nerve's function pays off. The notes list the core features. First, ptosis. That's the medical term for the droopy eyelid. And it can be quite noticeable because the main eyelid lifting muscle is out.
Okay, droopy lid, ptosis.
Second, diplopia, which is double vision. Because the infected eye isn't moving in sync with the other one, the brain gets two different images.
Double vision, got it.
Third, limited or absent eye movements. Specifically, as we said, moving the eye upward, downward, and inward. The notes stress these directions.
Eye stuck, can't look up, down, or in properly.
And fourth, pupillary abnormalities. This is a big one. The notes mention a dilated pupil, so it looks bigger than the other one, and it doesn't constrict properly when you shine a light on it.
Okay, so ptosis, diplopia, can't move the eye up, down, and a big sluggish pupil. That's a pretty clear picture. The notes also mentioned additional features. What are those high-yield visual clues?
Yeah, these are often the classic textbook descriptions. The notes say the affected eye is typically deviated down and out.
Down and out. Everyone remembers that phrase. Why down and out, though?
It makes sense if you think about which muscles are still working. The muscle pulling the eye straight outwards, the lateral rectus, that's run by the sixth cranial nerve.
Oh.
And the one that pulls it slightly down and inwards, the superior oblique, that's the fourth cranial nerve.
Right, those nerves are fine.
Exactly. So when all the muscles powered by the third nerve are knocked out, the unopposed pull of the sixth nerve outwards and the fourth nerve downwards component just leaves the eye sitting in that characteristic down and out position. It's the resting state when the third nerve fails.
Ah, okay. The other muscles are still pulling, so that's where the eye ends up. Makes it easier to remember. What was the other key additional feature?
The notes really emphasize that dilated pupil again. And they mention it's sometimes called a surgical third nerve palsy.
Surgical palsy? Why surgical palsy? Does that mean it always needs an operation?
It often points towards a cause that does need surgery, yeah. The notes link that dilated pupil specifically back to compressive causes, especially aneurysms. You see, the nerve fibers within the third nerve that control the pupil, the parasympathetic ones, they tend to run along the outside surface of the nerve bundle.
Okay.
So if something is pressing on the nerve from the outside, like an aneurysm slowly expanding, those pupil fibers are often the first to get squashed or are affected most severely.
Right, because they're on the surface.
Exactly. So seeing a dilated pupil alongside the other third nerve palsy signs is a massive red flag for a compressive lesion, which, as we said, is often a surgical emergency like an aneurysm. That's likely why the notes use the term surgical palsy. It connects that specific sign directly to a high-risk, potentially surgical cause.
Wow, okay. That is incredibly useful for revision. Dilated pupil plus the other signs equals think compression, think aneurysm, think surgical, think urgent. Okay, so for someone trying to nail these signs for an exam, ptosis, diplopia, limited movement up, down, and dilated pupil in the eye sitting down and out, maybe like the 4Ds in an O, droopy lid, double vision, eye deviated down and out, dilated pupil, and deficient movements. Or even simpler, ptosis, diplopia, down and out, dilated pupil. The notes really seem to hammer those last two.
Those are great ways to lock in the key features. That down and out position and the state of the pupil are definitely critical signs to tick up on fast.
Okay, so we know what to look for. How do clinicians actually confirm it's a third nerve palsy? And crucially, figure out the why. What do the notes say about investigations?
The notes lay out the standard approach. It starts, as always, with a really good medical history and a focused physical exam. Looking carefully at eye movements, checking those pupil reactions properly, assessing the eyelid position.
The basics first.
Absolutely. Then a broader neurological examination is needed to check if any other cranial nerves are involved or if there are any other neurological signs elsewhere in the body. You want to know if it's isolated or part of a bigger picture.
Makes sense. Confirm the third nerve issue, then check the neighbors and the rest of the system.
Precisely. And then imaging usually plays a key role. The notes mention MRI or CT scans. They specifically point out imaging is vital for looking at the brain and the structures around the nerve pathway, especially if you suspect an underlying cause like an aneurysm or a tumor coming back again to those dangerous compressive causes.
So the strategy is clinical exam gives you the strong suspicion and maybe some clues about the cause, like pupil involvement suggesting compression. Then you use imaging to hunt for or rule out those serious structural things like aneurysms or tumors. The notes seem clear on that.
That's exactly right. Imaging becomes crucial, particularly when the clinical picture raises those red flags for compression or a lesion in the brain itself.
Okay, diagnosis confirmed, cause identified, hopefully. How is third nerve palsy actually managed? The notes mention they refer to UK management guidelines.
The absolute main principle coming through in the notes is manage the underlying cause. You can't just patch up the eye signs. You have to address why the nerve failed in the first place.
Treat the root problem.
Exactly. They do mention managing symptoms too, of course, like maybe patching an eye for double vision temporarily, but the real focus is the cause. For milder cases, say if it looks like a typical ischemic palsy in someone with diabetes and, crucially, the pupil is not involved, then observation and supportive care might be appropriate. The nerve might recover on its own over weeks or months.
So not every single case needs immediate aggressive treatment.
No, but only if you're confident about the likely benign cause and there are no warning signs. For other causes, the notes mention specific treatments. Corticosteroids might be used if it's thought to be inflammatory, like in Tolosa-Hunt syndrome. And critically, the notes state that for compressive lesions aneurysms, tumors surgical intervention is often necessary. Again, tying management directly back to the cause.
It really hammers home that point, doesn't it? Finding the cause is everything because it dictates whether you watch and wait, give medication, or call the surgeon.
That's the absolute core message for management in these notes.
And finally, what's the outlook? Prognosis and complications. Can people expect to get better? Are there potential long-term problems?
The notes say the prognosis is pretty variable. It really depends heavily on, you guessed it, the underlying cause, and also on how badly the nerve was damaged. The good news is that recovery is possible, either spontaneously in some cases or following treatment. But the notes caution that recovery time can vary a lot, and unfortunately, some people might be left with persistent problems.
And what sort of complications might they face, according to the notes?
The notes list things like ongoing visual disturbances. Maybe the double vision never completely resolves persistent limitations in eye movement, and significantly potential complications related to whatever the original underlying cause was.
So even if the nerve itself recovers somewhat, the condition that caused it, like the effects of a stroke or the risks from an untreated aneurysm, could still pose long-term issues.
Precisely. Which is why getting the diagnosis right and managing that underlying cause effectively is so vital, not just for the IP palsy, but for the patient's overall health. The notes really stress that close follow-up and managing both the palsy symptoms and the root cause are key for the best possible outcome. You know, thinking about everything we've pulled from these notes, the nerve's job, the signs like ptosis and diplopia, the huge range of causes, from simple ischemia to brain aneurysms. Let's just pause on this for you listening. We talked about how varied the causes are, right? Some relatively okay, some life-threatening. So given that huge spectrum, what is it about seeing that specific combination, the eye stuck down and out and the pupil being widely dilated, that should immediately make a clinician think, hang on, this could be serious, maybe surgical, even before they've got any scans back? How does understanding the nerve's anatomy, where those pupil fibers run, elevate this particular clinical science to being such urgent warning bells?
That's a really powerful question. Yeah. It perfectly connects the dots between the basic anatomy, what you see at the bedside, the potential underlying dangers, and why acting fast on those specific signs is so critical. It really shows how much you can deduce just from careful observation. And that, I think, brings us to the end of this deep dive into third nerve palsy, all based on the excellent revision notes you shared with us. We really hope that walking through it like this, pulling out the key connections, and maybe adding a memory aid or two has helped make it clearer, more memorable for your revision or for anyone else tuning in. Keep reviewing those notes, keep testing yourself on those key features and causes. And hey, if you are revising, especially for something like the MSRA, don't forget there are resources specifically designed to help. You can check out pathmsra.com for more in-depth materials.
And there's also freemsra.com, which offers free questions and content, a great place to start.
Absolutely. So thank you for joining us on this deep dive. We'll catch you on the next one.